So it's 8 a.m. on New York City time. There's 12 hours difference, not 13 because we just had daylight savings time change and lost an hour. I'm a professor of surgery at the University of Pittsburgh and the Starzl Transplant Institute. I've been here 33 years. With 10 years of training, including liver transplant fellowship under Dr. Starzl and a very strong research interest. I have had an NIH-funded research lab for 27 years, and with basic science, I don't have time to talk about that today, but I did want to give you an update because I'm a very busy liver cancer surgeon, and I'm going to give an update on laparoscopic liver resection for hepatocellular carcinoma because this has made a huge advance in the quality and type of surgery for our patients. I'll start with what are the cancer outcomes with laparoscopic liver resection for open liver, because when we started doing this in Asia, Europe, and Americas over 20 years ago, there was big criticism that just to do Band-Aid liver surgery, we were compromising cancer outcomes. And back then it was hard with retrospective data, but I'm going to present you the current data, including a randomized clinical trial showing excellent outcomes. This table shows comparative studies from year 2001 to 2016, comparing LLR, laparoscopic liver resection, to open liver resection. So the second column is the number of patients in each study. This is the countries that they came from, Asia, Europe. One study from the United States. This is a journal they were published in. And these are, this is the 5-year overall survival rate, typically 50 to 70%, all 5-year, and not a single study. NS means not significant. There wasn't a single study in more than a dozen comparative studies looking at 1,000 patients in each group of inferior outcomes in cancer for laparoscopic liver resection compared to open. The conclusion from this table is lap liver resection is comparable 5-year overall survival versus open liver resection for hepatocellular carcinoma. This is the largest multi-center study from Japan, 31 hospitals. Patients were all matched for age, gender, child score, ICG clearance, hepatitis status, tumor size, location, number, extent of resection. The laparoscopic liver resection 5-year overall survival rate was 77%, and the Kaplan-Meier curves for open versus lap are superimposable. So a large multi-center propensity score match study from Japan. This is the only randomized clinical trial for HCC that's been published. There's been 2 that have been published for colorectal liver metastasis, one from Oslo, Norway, and one from Spain. But this study, I applaud the group. It was from Egypt, and it was a small study, but they did present it at the America's HPV meeting 2 years ago, or 2017 actually, and they published it a year later in 18. And they looked at 25 lap versus 25 open for solitary HCC less than 5 centimeters in child's cirrhotics that were straightforward to resect in the lateral or anterior peripheral segments. The patients were well matched for baseline characteristics, including 3.3 centimeter tumor size. The benefits of LAP had shorter OR time, less narcotic use, shorter time to regular diet versus open liver resection, but no difference in blood loss, transfusions, R0 resection rate, complications, and 1 year or midterm 3-year disease-free survival was comparable between the groups. So this was a positive randomized clinical trial in clinical favor of LAP liver resection without sacrificing cancer outcomes. So that is nice to see, at least a small randomized clinical trial. This is a second world review published 5 years ago in 2016 of 10,000 cases published of lap liver resection in the world literature. 2/3 were for malignancy, and of the cancer cases, half were for HCC. So hepatocellular carcinoma is a #1 indication in malignancy for laparoscopic liver resection. Mortality was less than 0.5%, comparable to any major open liver resection series. But benefits of the lap liver, they had less complications, less blood loss, transfusions, shorter length of stay versus open liver resection in a meta-analysis subset of 3,000 of these cases. This is a study from our group. I became interested in pushing the limits from child's A to child's BC. So in our database at Pittsburgh from 2002 to 16, we looked at nearly 1,000 laparoscopic liver resection cases. and 106 of those, about 10% were cirrhotic. We had 80 Child's A's, 20 B's, and 6 C's. And the outcomes of the study were that the BC patients had no difference in blood loss, transfusions, complications, or R0 margins versus the Child's A's. So in select patients, an advantage of laparoscopic is you don't open the patient, you don't interrupt the varices, collaterals, and there's less decompensation. Let me show you what it looks like. Here is a elderly man with not a transplant candidate, a 3 centimeter HCC at segment 3 of the left lateral section. This is the laparoscopic view, massive portal hypertension, recanalized umbilical vein, and massive varices, rock hard liver. This is the HCC here, which is slightly exophytic, which means it's harder to ablate. And so I don't have time to show the video, but here I resected this live, and here we get a negative margin. There's the tumor, and 1 year later, he was disease-free. And that's what it looks like, laparoscopic, just like a gallbladder surgery, with just 4 or 5 trocars. And we avoid decompensation, we avoid bleeding varices. In that paper we reviewed, and up till that time, we had 26 Child's BCs, and there was a smattering of others, but then we contributed, Roberto Trosi put together a international multicenter study that came out last month, British Journal of Surgery, 21 of March, 17 centers, 382 livers, 160 lap, 220 open, and we propensity scored match 100 in each group, all Child's B's. And again, similar to our single center paper, less blood loss, transfusion, less post-op ascites, morbidity, and shorter length of stay compared to open, and no difference in cancer outcomes. And we had mature 5-year cancer survival data. Actually, it was the lap liver was trended better, but 5-year survival 65%. We recently published more than 1,000 cases from Pittsburgh in JAMA Surgery. This came out about a year ago. We looked at our 3 time periods, our first 200 cases, our next 400, and our subsequent 400. And you can see on all parameters that we improved our performance. OR time improved between the more recent time periods. Transfusions went down. Pure lap versus hand-assisted improved. Complications dropped from 15 to 5. Conversion to open stayed the same, because if I'm doing a major hemihepatectomy, right or left lobe, I'll put a hand port in to start, where some people will use a vein and steel extraction port. Background cirrhosis will increase our cirrhotics, and our percentage of lap cases to our total is about 1/3 right now. We still do 2/3 of them open because of extreme liver surgery. So I will summarize by saying surgical resection or liver transplantation is the only chance to cure HCC. Laparoscopic liver resection for HCC has been performed in over 5,000 patients worldwide. That's probably an underestimate, with comparable oncologic outcomes, decreased liver failure and decompensation versus open liver resection. And lap liver resection for HCC can be done in selected Child's B cirrhotics with avoiding severe morbidity or mortality. So I will end there and be happy to take any questions.
Thank you. Very exciting. If you want to go out, then we'll see if anybody is going to ask a question. Otherwise, I'll ask a question.
Yes.
Yes. The first question is, you not only use laparoscopy, but you also perform a minimal invasive technique to take out the tumor. You don't do resection, at least by the example you showed.
Yes, that in a Child's B or C cirrhotic, we could not perform a major lobectomy because there would be liver decompensation and failure. So we can get away with wedge resections in the severe cirrhotics, but there's a lot of literature on major hepatectomy, and I do laparoscopic lobectomies all the time. So certainly for colorectal mets, for very early Child's age, you can do anatomic resections, but not Child's B and C cirrhotics. We're limited to minimally invasive wedge resections.
Thank you. Is anybody other question? Otherwise, I ask another question.
I look to you.
Dr. Erica Vila.
I don't see.
Yeah, Dr. Erica Vila has a question.
Yes. Well, have you got any experience with robotic resection instead of laparoscopic? Because we do a lot of them, and then we are very happy about, because it we surpassed the problem of portal hypertension, and so we are leaving laparoscopic in favoring robotic resection.
Yes, it's an excellent question. And my team published the first major paper. We did a 1-to-2 propensity score match of 57 robotic liver resections to 114 laparoscopic. We published that in Annals of Surgery about 7 years ago. And the robotic is is on the rise. In the field, there's a lot of laparoscopic surgeons that don't have access or trained on the robot, but there are more and more publications with use of robotic hepatectomy. We have debates at our national meeting at IHPBA. 3 years ago, I debated a robotic versus laparoscopic. I took the laparoscopic side. The robot is not cost effective still, because you have to take into account acquisition costs and annual maintenance fees. But short of the cost, there are advantages to the robot for getting to difficult segments like under the rib cage, segment 8 and segment 7, posterior, superior segments. The robot's definitely advantageous because of articulation. And we have in June, after this meeting, I will forward you a link. We have a Saturday, Sunday, our third annual International Laparoscopic Liver Society meeting. We had the first in Paris in 17, Tokyo in 19, 21 I was hosting in New York City, but we had to go virtual. So we have an amazing program plan, and there's an entire session on robotic hepatectomy and what its role. There's a session on minimally invasive living donor hepatectomy with the Koreans and your French surgeons speaking. We have 80 faculty representing 24 countries, including gender and diversity. So I will forward the link for that meeting after we're done, and anyone could please participate. Registration is free for the meeting. It's June 12th and 13th on the Saturday and Sunday.
Thanks a lot.
David, I have a quick...
Yes, please.
I have got a question.
Professor Wu.
Please, go ahead.
Oh, hi. I'm a gastroenterologist. I see a lot of our patients with the GI cancers going laparoscopy for their resection, the tumor resection, but very few for the liver. I'm just wondering whether the learning curve for the laparoscopy for liver is more difficult for the bowel or stomach gastritic.
The liver, it's a very insightful question. The liver was one of the last organs to be tackled laparoscopically because of the domain of fear of bleeding, the fear of air or gas embolus. But none of that has proven to be legitimate concerns, meaning there is not, those events don't occur. And the learning curves have been published from my team and others. I wrote an editorial about laparoscopic major hepatectomy learning curve. The data shows that initially it was all self-taught surgeons, and the learning curve for minor hepatectomy was 60 cases. That's been shortened to about 30 for minor hepatectomy, and the learning curve is 60 to 70 cases for laparoscopic major hepatectomy.
Oh, okay. Thank you.
Okay, so there's a lot of data on the learning curve.
May I ask a last
yes,
question?
Please.
Maybe? I saw your papers. Most of your patients have low albumin level. Do you try to, let's say, reestablish, improve the albumin serum level? It may happen that it doesn't work, but did you try?
Yes. We do not do that preemptively. That data was on the child's B and C cirrhotic, so they come in with low. But the one advantage of laparoscopic is that we don't interrupt collaterals and they don't get massive ascites. If they operate and we have mild ascites present, then it's important to close all the trocar holes because they can leak ascites out the hole. So sometimes instead of a 5 millimeter, we'll close the 5 millimeter holes and I'll leave a 2 millimeter pigtail and drain it dry for a day to just let the incisions heal. And if the albumin's low in that setting with ascites, we'll give post-ops salt pore albumin replacement, but we don't do it preemptively. And as you know, it's very transient. You can raise the albumin protein levels, but then they nadir out where they want to.
Excuse me, Dr. Geller, may I have asked a question?
Yes, Dr. Pang.
Yeah, okay. So something different from gastric cancer or colon cancer for the liver cancer is so often we encounter the big mass, big tumor. So what's your opinion on that? Do you think the big tumor using laparoscopic or robotic might compromise the laparoscopic surgery?
The principles are the same whether laparoscopic, robotic, or open. We have to get we shoot for a negative margin. It doesn't have to be a large margin, but in the early studies in laparoscopic, surgeons tried to stay under 5 centimeters, but now there are studies with, up to 10, 12 centimeters. So if it's a non-cirrhotic liver, say a colorectal met, we can do lobectomy, no problem. And if it's a large tumor, then you have to bring it out through either the hand port or a vein and steel extraction port. We do not morcellate the tumor like in a splenectomy. So you have to make extraction port and preserve tumor.
Actually, my point is, if you have a 10 centimeter tumor, even though you can do it by laparoscopic, still you need to have a 10 centimeter cut to bring the tumor out. I mean, that means that will sacrifice.
No, we do a 10 centimeter cut. We put it in a bag and pull it out through vein and steel incision, suprapubic, but it's very minimal pain from that. They're discharged post-op day 2 or 3 with that incision, low, midline, or vein and steel for extraction incision.
Yeah, okay, thank you.
So it can be done is the answer.